Welcome everyone. Thank you for joining our March Prime today. So, hi Prof. Lau. Today we have two presenters, one from Indonesia and the other one from our Singapore. So before I share about what is Prime about and introduce the speaker as well, just to share with you our Asia Pacific Medical Education Conference 2026, which will be taking place in Yiwu, China. So the workshop, symposium, panel discussion proposal, and oral presentation abstracts is open right now. So we do welcome your submission and hope to see you in APMED 2026. So every month we have this Priority in Medical Education Research Prime session on the first Monday of the month. So the purpose of having Prime is to have a platform for not only the young scholar, but also all the researcher from around the world, from this region specifically, to present your ideas, findings, as well as to have more networking and more collaboration as well. So without further ado, I would like to introduce the first speaker. Our first speaker is Dr. Azis Muhammad PUTERA from the Medical Science Center, Indonesia Medical Education and Research Institute, Faculty of Medicine, Universitas Indonesia. And I know Dr. Azis for quite some time. When he was I think he was still a medical student, if I'm not mistaken. So right now he's a budding junior researcher in medical education with special interest in system-based medical education, students' engagement, and curriculum design. He's also a practicing physician in hematology, endocrinology, and diabetes. And right now he has completed an internship at Medical Education Center for Faculty of Medicine, Universitas, Indonesia. Today, he's going to share with us a very interesting topic, which is the medical intern's intention to practice in rural area. So, I believe this presentation also won one of our APMAC free communication session, if I'm not mistaken. So over to you, Dr. Azis.
Thank you very much, Dr. Shuching, for the nice introduction. And thank you everyone for gathering to listen to my talk. And I believe Dr. Andre Muller will be the second speaker. So thank you very much for the opportunity to speak here. I'll just be sharing my slide. Okay, Dr. Shuching, can you see my slides clearly?
Yes, we can.
Okay. So, yeah. Thank you. Good morning, everyone. Thank you for the invitation. It is an honor for me to be able to present our research titled Indonesian Freshly Graduated Medical Doctors Intention to Practice in Rural Areas of Indonesia. So certainly this is a collaborative effort, and I am honored to represent my team. And Dr. Ducipa here is also our international collaborator. So thank you very much. Looking at the reasons why we conducted this study, we know that the maldistribution and malproduction of physicians are commonly faced problems worldwide, including the burden of and right now Indonesia faces many challenges in its health system, including the double burden of diseases, the disparity of health outcomes with the regions, and many factors. And to note, there are only around 176,000 active physicians serving a population of more than 255 million. So the ratio is a bit off, and it's certainly a far cry from the ideal ratio directed by the WHO. And when we talk about numbers, we know that most practicing physicians are still concentrated in the large cities of Indonesia and in the most populous islands. And certainly this leads to a disparity between health outcomes in urban and rural regions of Indonesia. Only 20% of physicians are practicing in rural areas where they serve more than 70% of the population. And right now, we currently have 2 provinces with virtually no practicing physicians at all. And out of all the primary health centers in Indonesia, 6% are still without any physicians. So we still have a lot of work to do. I'll just be emphasizing what the WHO has stated before, that without health workers, there would be no health system. Concerns regarding this workforce should extend beyond ensuring the availability of health workers, but to also include equitable distribution, accessibility, and empowerment of health workers to achieve the universal health coverage. And medical education here plays a important role, because we know that the education system and the health system is practically inseparable, and the education system must answer the needs of the health system, and the interaction goes so on and so forth. We know that the urban and rural disparity is associated with poor health outcomes in rural areas, and the archipelagic nature of Indonesia, the wide cultural and geographical diversity, the resource disparity in Indonesian healthcare system remain as major obstacles to attain the equitable health outcomes between regions. But we cannot put the blame entirely on the physician's hesitancy to pursue rural practice, since it is a complex interplay and a complex decision influenced by many factors, whether personal, professional, and sociocultural factors. And all of those influence the physician's intention to practice in rural areas, as well as their intention to pursue rural practice. And in Indonesia, we still have scarce evidence on what influences these factors, and whether the factors are influencing someone's decision to practice in rural areas, especially considering Indonesian context. And it is then crucial to identify the internal and external factors. Now, to give you some context, in Indonesia, we have this compulsory internship program where newly graduated medical doctors are mandated to serve in the suburban and rural areas of Indonesia, where they are doing semi-independent clinical practice under the supervision of a senior physician as an effort to mitigate the maldistribution. The interns are distributed in primary health centers and local hospitals all around Indonesia. And for those allocated in rural and remote areas, this internship program might be their first opportunity to experience rural practice. And the internship program is organized and funded by the Ministry of Health. And thus, we aim to entangle whether this initiative of the government actually have meaningful impact on the newly graduated doctors' intention to practice in rural areas. Again, it is then important to evaluate the program as well as other efforts aiming to solve the maldistribution problem. And thus, it is imperative to explore further how governments and medical schools can effectively encourage more Indonesian medical graduates to practice in rural areas of Indonesia. So yeah, this basically summarizes the introduction part, and we conducted this research to entangle the complex factors influencing the intention to pursue rural practice and what can be done to support them, aiming to tackle the wide disparity in health outcomes between rural and urban population in Indonesia especially. So we conducted a nationwide study adopting a sequential explanatory mixed method design and a total sampling approach involving intern medical doctors across Indonesia, targeting the 2023 cohort with at least 6 months of experience of work in their workplace. We targeted the whole cohort of the intern doctors, especially those in February and May 2023. And actually, this is a part of a larger research program, which we conducted. We actually conducted another research involving final year residents, and I hope that you will be eager to hear the results of our other project later on. And we then, although we adopted initially the total sampling approach, we still calculated the minimal sample size, and we gained these numbers. The research itself is compressed of two parts. The first part is the qualitative part, the quantitative part using the Google form, and then we continued the data analysis with the qualitative part using online FGDs. The quantitative data collection was done using Google form, which was then analyzed and then continued with the qualitative stage, where we conducted online FGDs and did the thematic analysis. A cross-sectional study was initially conducted to collect quantitative data using a modified questionnaire, previously validated by also our researcher in this project, Dr. Shahmar, to explore factors influencing the preference for rural practice among medical doctors. We then reviewed the questionnaire and items to evaluate their appropriateness. with the current context. And then we did also some cognitive interviews with non-respondent participants, and then we put their considerations into developing this new identity questionnaire. We define rural as an area that has a population of less than 25,000, or defined as remote, disadvantageous, and archipelagic regions by the Ministry of Health. The slide basically summarizes how we analyze the data. Following the survey, we conducted 1 to 1.5 hour online FGDs using the Zoom platform, involving 5 to 10 representatives from 3 different regions of Indonesia, which we divided into the west, central, and eastern part of Indonesia, to gain a more in-depth understanding of the motivation, intention, and barriers to practice in rural areas of Indonesia. 498 respondents from 73 out of 93 of medical schools participated in our study. And concerningly, almost 50% of the respondents preferred suburban practice location for their future practice. We can see here that it is concerning that less than 10% of physicians were willing to pursue rural practice. Most participants in our study were female and single, and had no prior experience of living in rural areas before, and most funded their medical study personally or was supported by their family. The slide shows the variable that we analyzed in the bivariate analysis, and several factors were identified as significant in the bivariate analysis, including the influence of spouse and partners, the quality of education for their children, availability of healthcare facilities, and so on and so forth. But when we did the multivariate analysis, only 4 factors were found to have significant association with rural practice. And these factors being prior experience of living in a rural area, accessibility to cultural centers and ethnic events, accessibility to the internet, which is a novel finding of ours, and then a funding resource during medical school. We found that those who personally funded their medical studies are more likely to pursue rural studies, and I will elaborate on this later on. And from the qual stage of our study, we identified 4 major themes and 37 sub-themes. The 4 major themes are shown on the slides, which are the role of the internship program in developing the MD's motivation and PIF, factors which generally influence choices for practice location, factors which influence intention and choice to practice in rural areas, and some policy recommendations to increase medical doctors' motivation, intention to practice in rural areas. We found that only a small proportion, or less than 10% of the participants, considered rural practice, and the underlying factors are multifaceted in nature, involving critical roles of the personal, cultural, and living conditions. We found a strong link between prior rural living experience and a preference for rural practice among the participants, and the internship program seemed to support the interns' motivation to become professionals in rural areas with limited resources. And it also exerts some positive effects on their PIF. And we found that those coming from a rural background were more likely to pursue rural practice with a higher intention to giving back to the community. Highlighting Indonesia's collectivistic culture, we found that proximity to family member and prior experience of family members were perceived as important driving factors, highlighting Indonesia's collectivistic culture. This is a novel finding of ours because we found that just from the stories of their family members who had been living in rural areas seemed to motivate them to also gain that experience, gain that rural living experience and rural practice. And ethnical events and cultural centers were associated with increased preference for rural practice, and these associated with the desire to explore and with expected more leisure time. Participants expressed a desire to explore culture from different cultures in Indonesia, because we know that Indonesia is the largest archipelagic region in the world, and we have more than 17,000 cultures and different cultures. So this might be an attracting factor for the participants to pursue rural practice. A sentiment particularly prevalent among those from the Western region, which are typically more developed compared to the Central and Eastern regions. And our interns also highlighted that effective communication and cultural competence as critical factors in their PIF. And those who personally funded their medical education was associated with more flexible decision to determine their future practice location. And participants factually highlighted the impact of finding resources on career choices, noting that the students sponsored by the governments and scholarships were more willing to practice in rural areas, either temporarily or permanently. And our findings have critical implications towards the health workforce policies and their role for quality and sustainable health system. And we urge for more emphasis that should be given to affirmation programs, scholarships, and official work ties after government-funded education with additional incentives. A notable initiative involves collaboration between medical schools and provincial governments, where funding is provided by the government and educational opportunities are provided by the schools, and graduates are required to return and serve their home communities. Political commitment is then crucial to address these multidimensional problems pertinent to retaining physicians to practice in rural areas, which requires adequate facilities and resources must be allocated by the government. It is also important for the program to widen access to the medical education, especially for those coming from a rural background. And more slots should be offered for affirmation programs, and this should be considered in the selection process. And we also urge for more exposure to rural medicine and rural practice in the curriculum. It is then expected that the exposure in the curriculum can be integrated and hence facilitating their PIF and future career trajectory. And here are some key messages from our research. Our study highlights the critical role of the internship program in driving the intention to pursue of rural practice amongst the newly graduate doctors. And we call for a comprehensive and collaborative health workforce policy, which involves multiple governmental stakeholders, including the Ministry of Health, Ministry of Education, the Ministry of Home Affairs, and the Ministry of Finance. And the roadmap of health workforce production and distribution, especially in this context for medical doctors, should be studied early from the selection and affirmation process of those candidates coming from rural areas. And the policy of increasing the number of medical schools in rural areas, as well as clear estimation of needs of medical doctors in different regions of Indonesia, which is periodically updated, are of utmost importance. And such policy should be followed by assuring support for the students during medical school and the opportunity to engage medical students in community-based learning activities in rural areas. And the distribution of and the distribution policy of medical doctors in rural areas following graduation should address different personal factors such as safety and security and adequate infrastructure and professional factors such as scholarship availability. And we also have some limitations. Our study is conducted only in our country, in Indonesia, and the characteristics might be dependent. And we need follow-up study with longer practice exposure in rural areas. Thank you. That will be my presentation, and I hope that we can engage more in the discussion. And we have published this study of ours recently in the HPP, and you can access the paper by scanning the QR code that I presented. Thank you very much.
Thank you, Aziz, and congratulations for your publication. So, I don't see any question coming in the chat, but oh, there's one from Andrea. So, he's asking or wondering whether should there be an effort for more medical students coming from rural area, and how could that look like considering how hard it is to get into medical school? Yeah.
Thank you very much for the question, Dr. Andre. Yeah, I have actually mentioned it before that we urge for more affirmation programs and more slots should be given, especially and should be given and reserved for those coming from a rural background. And I think that similar initiatives have been conducted in Australia, if I'm not mistaken, where some of their rural medical schools, allows special slots for those coming from a disadvantageous and rural backgrounds. So yeah, we aim to adopt a similar initiative there. And secondly, the our Ministry of Health has just recently created this new roadmap, which involve building medical schools in rural areas, which will then be guided by the already established medical schools like ours, and we will actually be responsible for the development of these rural medical schools. So yeah, such initiative is in early stage in our country, but yeah, we aim for more of such initiatives. I hope that answers the question.
Yeah, I think follow up from Dr. Mueller is also because students coming from rural area, they might not have as well resource as in the urban side. So they might not have the opportunity even to study well and enter medical school. So I'm not sure whether is there any effort or initiative coming from the government side. Yeah.
Yeah, actually, some initiative include, collaboration with the local governments, because we adopt decentralization, decentralized policy making. And for those in provincial levels, their education department will actually screen for potential students in their local high schools, which um, which they seem which they deemed to have competent skills needed for them to become medical doctors later on. And then they will prioritize these potential students to pursue medical studies. So yeah.
Okay. All right. I think the Jipa has a question.
Yeah, a very quick one, just a comment, and also sharing what Andre raised earlier. So one of the things I think this study, which can go beyond just the Indonesian setting, is that the important finding that it is really critical for if we want to send anyone, whether to a rural area or any other place, we need to give our students an exposure or experience in those areas, a deep experience and exposure. So whether someone does not want to go to even in Singapore to a hospital that is deemed as not very good, you need to give them that exposure. Earlier the better, right? So when they are there, when they link up with those organizational structures, the leadership, the culture within that setting and context, they feel more comfortable and they are more likely to go there. We talked about the Australian setting. So yes, Australia had this affirmative action where they actually got in the rural students, and also they had a bond that the rural students must go back and serve for certain number of years. But if you look at the studies conducted, that has not been very successful, because they after the bond, they would just come back to the city or they move out. But what has really worked now is that not only that they provide extra support for those students coming from rural areas, but also that they have rural schools. They have established rural schools which are very popular. For example, like in University of Queensland or at Griffith, they have these rural schools where the students actually have a longitudinal attachments. They don't go from medicine to surgery, etc., rotations, but for the entire year they are with the rural school. And they have found that when you do that, the more practitioners, the students coming from the rural schools tend to go back and stay, because they see the value. They see that they are part of a community. They feel that they're attached to that community. So I think those are important things. Even from this study, I think that is one real key thing. Thank you. Thank you, Aziz. Congratulations.
Thank you very much. Yeah, I think you have elaborated some important points, Dr. Jipa, and I think that it's two different things actually to how we attract those to personal practice and how we retain them. And for long-term placements, this might require further study to entangle. Yeah, because that is an important point that we are trying to make. It's a different thing to how to attract them and how to retain them. Yeah.
Yeah. Yeah. Speaking about retaining the practitioner, there's a question of asking whether there is any incentive or financial or upgrading for those who are working in rural area.
Yeah, some special incentives are given by the government, but
Okay.
actually we found that the incentive, while it plays an important factor in driving these physicians to pursue rural practice, it's not the most important. It's
I see.
the
Okay.
social security and access to education for their children. that that have been stated many times by the participants. So yeah, it's and there has been additional incentives, but to retain them, I think we need much more than the incentive.
Yeah, definitely. Yeah, yeah. Then I want to ask about one of the questions, because you mentioned about the prior experience is very important and internship program actually helps. But then I also see from the results that it's only it's less than 10% of the students actually chose to work in the rural area. So despite having all those prior experience, do you have a so-called statistics or outcome to show that after their prior experience, the internship program, those who would like to go to rural area has increased?
Okay, that is actually a goal for our next study. So
Okay.
because as I have studied earlier, the cohort that we aim for were those with only 3 and 6 months experience in their current workplace, and we aim to see this in the more longitudinal projection. So yeah, we are aiming now for the 2 years and 3 years cohort, and we are still in the data collection phase right now.
I see. All right. Okay, there's another question coming in, but I'm not too sure I understand, Andrea. How about other healthcare professionals? Are there some, because a lot of in some kampong health center in Malaysia are run by nurses and others.
Yeah. This is interesting because a lot of rural clinics in Indonesia are actually run by midwives actually.
I see.
And some experienced nurses, but our nurses, the nurses in Indonesia, I think the system is a bit different compared to the US, for example, where if I'm not mistaken, some NPs are able to prescribe and make a simple diagnosis, if I'm not mistaken. In Indonesia, the nurses are not allowed to do that. But in real world settings, we do notice that many clinics are run by midwives. But we have another research on this. The results are concerning because in those clinics where the health facilities are run by health professionals other than a physician, the outcomes is usually poorer than those who are run or with a service provided by medical doctors. So yeah, one of the main aims in our research is to ensure that each health facility needs at least one functioning doctor there. I am not trying to discredit our colleagues. They are amazing. But in our settings, I think the education system still does not give the nurses and midwives that competence. So yeah, we are still very physician centered in Indonesia.
All right. Thank you so much, Aziz, for the clarification and your presentation. It's really enlightening, okay, especially to look at how people think about the rural practice. So we look forward for your next research, okay, because you mentioned there are quite a number of research ongoing. So hopefully we can hear from you again.
Thank you so much.
All right, thank you. You can stay to listen to the second presentation. I will invite my colleague Gillian to introduce the second speakers. Thank you so much, Aziz.
Thank you, Suching and Aziz, for the presentation. We'll now move on to the next speaker. We have Dr. Andrea. Dr. Andrea is from the Sawsweet Hawk School of Public Health, and he will be sharing with us on the topic empathy in healthcare students, why it matters, where they start, and how to develop it. So, Dr. Andrea, go ahead, over to you.
Thanks, Julian. Yeah, just let me take over. Yeah, hi everyone. Good to see you all. Very interesting talk just now. Thanks, Aziz, for sharing. And I had a lot of thoughts going into my head, so I hope I can focus back on my actual session myself. But that should be fine. Okay, let me quickly find my slides. All right. All right, super complicated title, but we go through it step by step, so no worries about this. But I'm going to start the session with big question, who am I? And why am I even talking about this kind of topic? And in addition to being a new father, just 3 weeks ago, we had our second child. And so apologies if I'm a bit messy today. I'm many different things, but I like to say that I'm more an academic and a teacher, and I'm not a healthcare professional. So I've never been trained in any healthcare profession. So I guess that's good to foreground this. However, I think I have the experience of a patient going through different healthcare systems, and I see a lot of healthcare professionals because of certain issues that I'm dealing with myself. And from a patient perspective, and this is how the story started with me looking at empathy, I found there is a need to look into it a little bit more deep because I'm directly affected by empathy that healthcare professionals show. And gladly enough, I can sort of translate my own experience and what I learned along the way as a teacher of healthcare professionals, and I have made it one of my main missions to nurture sort of psychosocial skills and specifically empathy in healthcare professional students. So this is how I really come to this story. So what is the origin story of this empathy project that we do in healthcare professional students? Maybe I start with this. First, you might realize that there's quite a bit of pressure to run healthcare systems like a McDonald's restaurant, right? You might have seen that you need to see as many patients as possible. Everything needs to run very smoothly and so forth. And that often leads to empathy being less important. So a couple of examples here, right? So how a McDonald's restaurant runs, it runs very efficiently, right? So in a medical or healthcare setting, oftentimes you aim for very brief consultations, so very efficient, get the most information out in a very short time, right? It's like your drive-through window. Similarly, everything should be rather calculable, right? So in a McDonald's restaurant, you want to get through as many customers as possible. And similarly, in a healthcare system or in a healthcare setting, there's always some kind of numbers you need to see. So when you schedule an appointment, you have to see 20 patients in the morning. So that needs to be all calculable. Second or third, things need to be predictable, right? So if you go to McDonald's, your Big Mac tastes the same everywhere. And even sort of when we look at healthcare practice, I've experienced many times things should be more and more predictable, right? In some weird way, it means that we should treat everyone the same. And with our increase on technology and standardization, that's in a way what we want to achieve. And lastly, everything should be rather controlled. And so at McDonald's, the worker is oftentimes not really in charge of anything except of responding to orders and looking at a screen on how to assemble a Big Mac. So there are certain processes and it's very controlled. And similarly, one could argue that for a visit to the healthcare professional, a lot of things are rather controlled. There's less autonomy over time that healthcare professionals might have because we over-rely on electronic medical records and start the conversation from there. And for me, to be quite honest, I'm a public health academic. I look at this and think, wow, excellent. Well, that allows a system to have good access, right? All these things help to run things efficiently, so that increases access. It keeps things affordable, right? So if we increase the consultation times and make everything very person-centered, it's getting harder to afford, right? Because a doctor's time or healthcare professionals' time costs money. And it also keeps things obviously a lot more sustainable because it's a well-oiled and well-functioning system. Obviously, we are not dealing with systems, we are dealing with actual people. And in my point of view and in my own experience, individuals have needs. And these needs are often not in line with running healthcare like a McDonald's restaurant. And here in this world, empathy is actually very important for various reasons, right? When you see a healthcare professional, you want to be understood. So on the part of the healthcare professional, They need to be asking questions, need to be listening with an open mind. They need to do some active processing of the information that they are coming in. Then there is communication, right? You need to acknowledge how the other feels, what their experiences, their beliefs, maybe their wishes, acknowledge feelings, acknowledge worries, and all those kind of things. And then obviously, empathy also involves having this person-centered intention to help, not helping based on an SOP or based on some sort of clinical criterion, but based on the person you have in front of you. And so for me as a patient, right, I give you a big thumbs up, right? Because there is a lot of evidence, not just my own, but in the literature that tells us that a healthcare professional who acts with empathy, they can induce immediate relief, right? You can trigger psychological responses that translate into your body. It can also build up trust if you feel heard and understood, right? It builds trust. And obviously all these things also lead to better treatment outcomes and overall health in the long run. So the question that I came up with is empathy necessary or is it just nice to have? So to me, as a teacher, I think we need healthcare professionals who combine, in a way, the science of cure, the science to cure, but also the art to care. And that for me has a lot to do with empathy. And this is, again, the origin story of the project on empathy in healthcare professional students. And let me give you a quick overview of the overall project at this stage. So what we did is we took in healthcare professional students in their very beginning, early stage of their study. They haven't actually not really received any healthcare education. And we took them in a baseline and assessed their empathy using validated tools. And we also looked at their empathic care intentions. So do they have intentions to, practice with empathy in the future? And then we followed those, or we're following these students up over a longer period of time, and most crucially, the first 1.5 or 2 years, where these students go through a curriculum that is explicitly but also implicitly designed to nurture and develop empathy. And then we follow them up beyond that point to look at how empathy might develop beyond this specific curriculum. And as you see here, at the bottom of the graph, there are 4 different lines, and this represents different healthcare professional students we have in this course, but also in the study. So again, back to sort of Azis, that's why I asked the question around healthcare professionals in general, or more healthcare professionals. So we recruited essentially nurses, dentists, pharmacists, but also medical students to this study. And I know you would all like to know how this all pan out, but the study is still ongoing. The data collection is still running. So I will focus today only on one question. And this question comes from the baseline of the study and is simply how empathic healthcare professional students enter their training. Why does it matter? Why does it matter how empathic healthcare professional students enter their healthcare training? You might think, well, why do I care? Well, there's quite a bit of research that looks into this, and there are 3 kind of key messages here. Students who have an empathic orientation at the beginning of their training are actually better prepared for these more patient contact competencies that are trained oftentimes later in the curriculum. So if we selectively only look at students who are great in math and science, they do very well in these sort of areas. But when it comes to these patient contact competencies, then somebody with a good empathic orientation is very well placed. They do really well. Secondly, if you have people who come in with this orientation to really care, they are often more resilient to that decline that happens sometimes in empathy over training. So what we see in studies in the Western world especially is that students, when they enter clinical years, the empathy drops over time. But students with higher empathy at the beginning, they are less susceptible to those declines. And lastly, students who enter with an empathic orientation are more responsive to training in empathy. So that means they're likely to engage a lot more with empathy and benefit from these development opportunities that we provide. So a very simple example is that somebody who is more interested in the math and science aspect of healthcare might switch off in these trainings where we try to teach those things that are often perceived as very fluffy, but from a patient perspective are not fluffy at all, compared to somebody who is very in tune with empathy and person-centered care. They might actually take a lot more out of these training sessions. So now in the background, you can hear my baby crying, so that gives me a bit of a sweat right now, but I think it's all good. So just in case you wonder, my wife is around. Okay. So what we did is we looked at empathy at newly enrolled students. We recruited 646 of them. And I'm just going to briefly show you the results here. If you want to know more information about statistical analysis, feel free to ask me in the follow-up. But here is main information. So we had 109 median score on empathy. That doesn't mean all that much. I can only tell you that the maximum score of the scale is 140. But what does that really mean? And I think the most meaningful analysis that we conducted was around this one, empathy by discipline. What you can see here, hopefully, is that medical students and dentistry students have quite a decent amount of empathy if we consider it compared to the pharmacy and nursing students. And so key findings here that the medical students had significantly higher scores than students from other disciplines, whereas dental students had significantly higher scores than the nursing students. And not too surprisingly, we found a very similar picture when we looked at the empathic care intentions. So these are the intentions that students have to care in a person-centered empathic way in the future. And the results are almost a mirror image. Again, the medical and dental students had significantly higher scores than pharmacy and nursing students. So we're seeing two clusters in a way in our data. So I give you now a 30 seconds reflection, and maybe you can put something into the chat. So the question is here. So if we know that students with strong empathy are more likely to succeed, especially in clinical competencies, retain their empathy, and grow even further with training, shouldn't we consider empathy during admissions? So let me pause for 30 seconds, and then maybe you want to put in a quick note in the chat here, and I can have a look at it. So what do you think? Should we do that? Okay, thanks so much. I saw some other questions there, and I will take them later, I guess. But I saw some that sort of responded in a simple way that I can process right now during the presentation. But so the simple answer is yes, of course, we shouldn't try to get students in or people in who have a very good people and empathy orientation. That's sort of, I think we can say that that is true. However, the world is a little bit more complex. So let's look at the two clusters that we just saw. So if we look, for example, at medical and dental school, right? Medical school have quite stringent admission procedures, and you will still see a long queue of applicants wanting to go into medical and dental school. So no matter how difficult you make the admissions process, and no matter how much you add, so for example, empathy, you will still have a lot of applicants. So difficulty will just be here to find the best of the best and the most appropriate. And we could think about adding sort of a validated empathy tool and screening for that as a criterion. So that is one answer. The second answer is for the other group of nursing pharmacy students, and here's exactly the opposite. Looking at the global but also local workforce in healthcare professions, we have an especially big issue in terms of nursing and pharmacy. So here, nursing and pharmacy schools and departments are actually needing to find the applicants. So if we are already struggling with recruiting enough students who want to study nursing and pharmacy, then it might not be a good idea to now add another admissions criteria in, because we are shrinking our pool even more. So again, in theory, we would love to screen for empathy, but that might not always be practical, especially for nursing and pharmacy. So now what are we going to do? Well, if we want empathic healthcare professionals, but we can't impose strict empathy-based admissions criteria across all these disciplines, what's our alternative? And I guess the alternative is empathy training, right? That's really the other tool that we have. Once students enroll, we can train for empathy in one way or the other. And how are we trying to develop empathy? I will just touch very briefly on it, and that's part of the initial slide on the overall project. And that's sort of through our common core curriculum for all 900 healthcare profession students, where we implicitly and explicitly try to develop this very crucial psychosocial competency of empathy. And the way we're doing this is through 5 basic strategies that are evidence-based in some way or the other. So it's didactic training, where we try to make students intellectually understand that this is important, and also reinforcing the role of empathy in healthcare. We do it through perspective-taking exercises, where we try to get students to be in the shoes of somebody else, diverse people, and try to walk in their shoes. We're trying it through communication and interpersonal training. It happens later in the common curriculum in years semester 2 and 3. Reflective exercises, where they critically examine their experiences, their biases, perspective on patient care. And we also have some, although very minor, exposure to arts and literature, because this helps to see in the many ways in which feelings and experiences can be expressed. I have an example here. I don't think I need to go through it, but we did this with generative AI in our last run, where we essentially programmed the software as the generative AI being a patient with low health literacy, hasn't seen a healthcare professional for a while, and had other characteristics. And then we asked students to help this patient along, and this patient could have come with a toothache for a dentist, a diabetes check for a nurses, I think it was, and then nutrition advice or a pain medication collection from a pharmacist. And the students had to essentially empathically engage with that patient, and that was all done on generative AI, and they needed to walk in the shoes of this patient. So if you want to have the link to the activity, I can share this with you. And I think we are reaching the end. So has empathy changed? I can't tell you yet. The suspense is really killing me. So my other child is 5 years old. She loves to watch Frozen. And so I decided, and I told her, and I promised her, my presentation today has my favorite character of Frozen. So here you go, Olaf, as he likes to say. The suspense is really killing me, but we must wait for the results to come in soon. So thank you so much, and happy to take questions or comments.
Thank you, Dr. Andre, for your sharing. My favorite character in Frozen is Olaf as well, so that's nice to know. When you posted a question earlier about how admissions could potentially include a criteria on empathy, so there were some rather interesting points that were raised in the chat. So I thought perhaps we can start with looking at those. So from Dr. Aziz, he said, how do we ensure that the perceived ability to empathize isn't just a one-off occurrence?
Oh, wait, I can actually read the question myself.
Sure. Can you hear me?
Yes, I can hear you. Yes. How do we ensure that the perceived is just a one-point occurrence? I'm not understanding the question entirely.
So I think what Aziz is trying to get at is that how do we know that at the point of admissions, when we do the perhaps the test to determine whether the student has a certain level of empathy, how do we know that this is not just a one-time performance by the
Is
student?
it a fake? So as Dujiba said, is that a fake? Okay, is that a fake? Yeah, that's a very good question. Obviously, when I looked at this, I brought up several pieces on this one. That was one of the big things. I'm trained in psychometrics, so this is a big deal for me as well, validity and reliability. Okay, to be very fair, you can never totally discard that at all, because after all, you're measuring a personality trait, and you're measuring a part of a personality trait where there is a lot of social desirability going on there. So you want to be perceived as empathic, even if it's anonymized, which this questionnaire is. This is no ID checking. I don't know who responded what, but even to yourself, you want to make sure you don't look like, a big, how do you say? I don't know. I don't know the good word that is polite to say, but anyway, you know what I want to say. Yes, you can never discard it. However, I dug into it a little bit, and apparently there's some research with this particular tool we used where they found that this social desirability bias is not as bad as one would think for this particular thing. So while you can never fully remove it, and you can probably take it with a grain of salt, but I also don't think it's totally invalid, the results here. But I get your point.
So it's perhaps something that is a measure, but it might not be something that we want to take wholesale.
Yeah, you can never. I mean, you can also not take wholesale in interview, right? If any psychosocial instrument that you take, I'm working in other areas as well on physical activity. People don't know how active they are, so it's impossible to do, but we can mitigate it a little bit. So it was anonymized. We highlighted that there's no penalty. We don't follow up on anything. So we at least ensured all those things that are as good as it gets, I guess.
Thank you. So if you so there are no questions in the chat at the moment, but for our participants on the floor, if you have questions, do feel free to put them in the chat. I have a question about you mentioned earlier about using AI as a means to teach empathy. Is that could you elaborate a little bit more about that, and what are some of the challenges or advantages from using AI?
Yeah, sure. I mean, obviously, this is so initially in the first or second run of this whole curriculum with 900 students, also a massive number, and teaching of psychosocial skill is very difficult. So initially, we always did some, case studies, but then with the generative AI, I kind of decided to design an exercise. So what I essentially did is to give a 2-page prompt into ChatGPT for this purpose. And I told ChatGPT exactly what it should be doing or how it should behave. And ChatGPT was to behave like an actual patient in Singapore, for this matter here, right? Who has low health literacy, who hasn't seen a healthcare professional for a while, who doesn't trust healthcare professionals maybe. And I gave it a lot of other little characteristics that ChatGPT would randomly choose to make a realistic scenario. And then I told ChatGPT, okay, what you need to do is to pretend that you are now this patient, and the person you will be interacting with will be either a medic, a nurse, a dentist, or a pharmacist, and you will have an interaction with them, and you come in with a very specific issue. So if it's a dentist, then it would be you coming in with toothache. Or if it's a pharmacist, you come in to collect pain medications. And then the conversation is essentially like a natural conversation where the patient comes in, hi, I want to pick up my medications, and then the students have to essentially take on the role of the pharmacist and start talking to this patient. And the idea is for students to really listen, to understand what's going on. And in the conversation, there come up things as, oh yeah, I always forget my medications, but sometimes my daughter reminds me, right? And then you as a healthcare professional should be latching on this because, oh, so I understand you have a daughter. So is there a way we can support you with the help of your daughter? I can show you this is like a huge interaction that I've done myself. And it was super nice because I asked ChatGPT that after the conversation is over, the ChatGPT needed to give a score of how well they did, the students, and they needed to give specific advice that relates to empathy and psychosocial competencies. And then the students had to reflect upon that feedback, and so that was the whole loop that we went through.
Okay, thank you. It's wonderful how you have managed to use AI in this. Digital, yes.
Yeah, a quick one. Andre, I also have insights into this because I sit down with you guys when we discuss the things. But that will be very interesting for the participants here. You mentioned also that in the initial survey, that you found that medical and dental students have a higher empathy score than the nursing and pharmacy students. I know that this could be speculation because you have not gone into more in-depth interviews with them and try to deconstruct this matter. But any thoughts on that? Why, or any thoughts from your side? Why you see this kind of pattern?
Yeah, of course, that's like the biggest question on my mind, and I dug into it quite a bit. I like to think those things through quite a bit. So one thought that we had was that medical and dental students are just very well trained in answering, and that goes back to your initial point, Jillian, but also Aziz had that point. They're just much better trained sometimes to answer questions in a certain way. Again, it's not the whole answer because we know it's reasonably valid, but there might be something along those lines. But also, more simply speaking, right? If we put this a very positive spin here for the medical and dental school, we could say, well, admission seems to actually work quite well because medical and dental school has quite stringent admissions. And I went through their process, not myself, but I looked through what this is. And there are aspects of empathy, the interviews and things like that. And we could argue that is probably something that's really helpful compared to, let's say, the nursing and the pharmacy school. As I said before, there is already a struggle to get enough students in. And if we now start a very stringent admissions, you might not be able to retain a lot of students. So there might be an issue on the admissions itself. So these are the two things I can come up with at the moment, the biggest ones.
Thank you, Andrew.
Thank you, Dr. Thank you, Andrew and Dujipa. So yeah, we have reached time, so I don't want to keep our participants back. And I'll hand it over to Sushi to close the session. Thank you.
Thanks, Jillian. Thanks, Andrea, for your presentation. I think empathy is a very important topic for us to look at it as well as a healthcare professional. And like y'all, like Andrea has correctly pointed out too, sorry. What is the reason behind that pharmacies and nurses students have less empathy? So maybe something for us to explore further. And I hope to have more conversation on this as well. So thank you so much for two presenters today. Next month, okay, the month of April, we'll have two more presentations. I allow my colleague to put on the screen first. All right, we actually have two presenters, one from Taiwan and not one from Japan. So hopefully you will be able to join us next month for our Prime session. And once again, thank you so much for the Prime session today, Dr. Aziz and Dr. Andrea, for your wonderful presentation. Hope you all enjoy your lunch and the rest of the day. Thank you. See you.